Insulinomas. Insulinoma is a functioning neuroendocrine tumor of the pancreas that causes hypoglycemia through the inappropriate secretion of insulin. And in 90% of the cases, the insulinomas are benign. 80% of the time, the insulinomas are solitary. However, in around 10%, these tumors can be associated with Man-1 syndrome. Uh, uh, these tumors can present with neuroglycopenic symptoms and seizures. People try treatments as useful as ever in diagnosing insulinoma. There is the symptoms of hypoglycemia, plasma glucose of less than 2.2 millimole per liter or less, and the resolution of symptoms with glucose. The gold standard investigation for establishing the diagnosis is 72-hour fast. However, a shorter duration of fast, that is 15-hour, which is repeated on 3 separate occasions, may be used as a screening tool. The diagnostic criteria include laboratory blood glucose of less than 2.2 millimole per liter, concomitant inappropriate insulin elevation, elevated C-peptide, and proinsulin, beta-hydroxybutyrate rate of less than 2.7 millimole per liter, and absence of sulfonylurea and metabolized in the plasma urine. So tumor localization is done by different treatment modalities, diagnostic modalities, and among that, the most important one is with the highest sensitivity is intraoperative ultrasound with a sensitivity of 90%, endoscopic ultrasound with a sensitivity of 80%, MRI can diagnose in 20 to 100%, and venous sampling can diagnose in 84%. Arterial stimulation with calcium oxygenation followed by the venous sampling can localize approximately 90% of the insulinomas. Endoscopic ultrasound may identify tumors as small as 5 millimeter, and somatostatin receptor scintigraphy has been shown to be useful in detecting insulinomas, but it's dependent on the somatostatin receptor subtypes expression by the tumor. So the treatment of insulinoma is basically surgical, which includes enucleation of the tumors, partial pancreatectomy, Whipple's procedure, or rarely total pancreatectomy. Post-operative hypoglycemia may occur even with partial pancreatectomy. Medical treatment to control the symptoms may be achieved using the diazoxide alone or in combination with octreotide before the surgery or in those with a high surgical risk. Radio-level somatostatin analog therapy may induce biochemical and symptomatic response in patients with malignant insulinomas. Everolimus may be useful in metastatic insulinomas, but has a significant side effects. The prognosis of insulinoma following the removal of the solitary insulinomas, life expectancy returns to normal. In malignant insulinoma, especially to the liver, then these patients may have a natural history of for years and may be controlled with medical therapy or specific anti-tumor therapy using the streptozocin or fluorouracil. The average 5-year survival is 35% for malignant insulinomas.